I'm Alexis Nichols. I'm a trauma surgeon at the University of Kentucky. So I take care of fall patients every single day. I also have a master's in public health and with a focus in injury prevention. And I work with the University of Kentucky Trauma Center Injury Prevention Coordinator pretty closely on our programming in the hospital and the city. Today I'm going to talk about the cost of falls from a healthcare and non-healthcare perspective. Let's see. Right. So there are two objectives for this talk. We're going to list the healthcare and non-healthcare costs for falls, and we're going to understand some cost-saving benefits of implementing a falls prevention program. So I want to get you all thinking to start about one of our typical trauma patients. An 85-year-old woman presents to the emergency department after a ground level fall. Oftentimes they're either a trauma alert or a trauma alert red. The red is the higher activation. It just brings more people and more resources to the patient very quickly. They are brought into the trauma bay, where we'll start with the emergency department. I just want to point out that the US spends about $50 billion a year on falls, with respect to just medical costs. So in the emergency department, if they are just a trauma alert, initially they'll see an emergency department physician, usually a team, including a resident and an attending. Their charges are about $400 for a higher level visit. They're going to get a bunch of labs, which cost various amounts, but we have typically a trauma lab panel. So all of these things get automatically ordered. That costs several $100s. Depending on the story and how the patient is, the patient can get a head CT, CAT scan, a neck CAT scan, chest, abdomen, pelvis, thoracic spine, lumbar spine, plus extra images of the neck and the head with contrast. So that adds up very quickly. And then if they have any injuries, deformities, bruising, pain of their extremities, they're going to get x-rays of those as well. And generally we have to get x-rays one joint space or one level above and below the area of injury, because you're just at higher risk for injuring those areas, and it changes the way the orthopedists might splint that fracture. Any ultrasounds also cost about $1,400. If the patient requires any procedures like fracture reduction or traction placement, those cost about $3,000. And then the sedation for those procedures can cost $200 or more. All the supplies are covered under an ED facilities charge, which is about $4,000. And then medications are separate, and any sedation medications or pain medications altogether cost about $125. And I want to point out that I got these charges from my own bill when I broke my ankle from falling. So recently. So this is all at UK. So next we're gonna move our patient to the intensive care unit. Oftentimes our elderly patients, especially if they have broken ribs, can require intense nursing interventions. So getting the patient up and moving, extra oxygen requirements, using incentive spirometry to prevent pneumonia. Oftentimes they don't require a ventilator unless they also have a concomitant head injury. But ventilator days in the ICU cost about $7,000 a day, and non-ventilator ICU days cost about $5,000 a day. We have scoring systems with respect to rib fractures that help us determine whether a patient is going to benefit from ICU stay versus a progressive floor or whether they could go home. It's called the RIG score, RIG, and we utilize that on almost every single one of our rib fracture patients. When we're deciding whether a patient is ready to leave the ICU, we also use a different score that's been validated called the PIC score, PIC. And that helps us determine whether somebody has high or low risk for return to the ICU for respiratory failure with regard to their rib fractures. So there's quite a bit of evidence about resource utilization in these patients, particularly useful in elderly fall patients with rib fractures. Some procedures that are sort of special to the ICU include a central line or an arterial line. Those cost variable amounts, but for example, a central line can cost $3,000 in materials and physician costs. If they're doing well, they meet their PIC score requirements, they're on low levels of oxygen or no oxygen, then the patient gets moved to the trauma floor team. This costs an average about $2,500 per day. Again, this includes bed costs, medications, nursing, physical therapy, physician or advanced practice provider costs. And the average length of stay total from emergency department to discharge from a hospital is about 7.9 days. I can tell you that the average length of stay for elderly fall patients tends to be a little bit higher. Because they have more medical problems that we're managing that can become disjointed or out of whack when they're in the hospital, but also because they are often discharged to a rehab facility, either acute rehab, subacute rehab, or nursing facility. And once we decide that they're medically ready, we usually have to wait about 3 to 5 business days before the insurance says yes, and we find a place for them that says yes, and that place has a bed, and we arrange transport. So their medical requirements are probably close to like 3 to 5 days, and then the other days are just waiting for a bed in rehab. If the patient requires an operation, they have a hip fracture that needs to be repaired, they have tibial plateau fractures, ankle fractures, both bone and forearm fractures, spine fractures that need to be stabilized. Obviously, that significantly increased healthcare costs. So surgeon costs are variable. This is dependent upon the procedure that's performed. Anesthesia costs, again, I took these from my own itemized bill, but there's an approximate base of like $2,800 and then a per minute charge of $10 per minute for anesthesia. That's just the physician cost. Medications for anesthesia and pain and local anesthetic were about $700. And then obviously instruments and implants are variable depending on the procedure that's being performed, but also several $1,000s each. OR time is very valuable, very expensive. So the first hour is over $10,000, and then it's billed every 15 minutes after that at a rate of about $1,400 per 15 minutes. This is for an orthopedic operating room. The charges are a little different depending on where you're at, but most of our fall patients are having orthopedic procedures. And then there's the post-anesthesia recovery time that's also charged by a 30-minute increment for about $2,000. And then in phase 1, where the patient has much more frequent needs, it's a $28 per minute extra charge after that first 38 minutes. And then phase 2, where they're more awake, generally they're eating or drinking, and the nurse is just monitoring them for pain. It's about 12 minutes or $12 per minute. And then again, most of our elderly fall patients end up going to an inpatient rehab facility. The differences, for some of you who are unaware, are acute inpatient rehab. Usually they require a medical need. So they have to have a medical problem that's going to require a physician to manage. That physician would be a physical medicine and rehabilitation doctor usually. And they have to be able to participate in 3 hours of physical therapy, occupational therapy, rehab every single day. So they have to have the stamina for that. And they have to have a safe place to go home to where they're going to have support. So the social aspect is really important. Subacute rehab, usually less of a requirement as far as like medical need. The rehab is less intense. It's about an hour to an hour and a half every day. And there isn't necessarily as much of a requirement to like have family support because sometimes patients can be discharged to nursing facility, et cetera, from subacute rehab. And then obviously nursing facility is sort of the lowest level of rehabilitation with regard to like physical therapy intensity. And then the average length of stay is entirely variable depending upon the injuries. If they have a traumatic brain injury or a spinal cord injury, they can go to those specific rehab types. So traumatic brain injury and spinal cord injury rehab have specialized physicians and therapists that work with them. Regular acute care inpatient rehab is usually anywhere from 7 to 21 days. And oftentimes, unfortunately, it's entirely dependent upon what your insurance will pay for. Any questions about healthcare costs? I know it's a lot of numbers, and a lot of them are very big, ugly numbers. Okay. Let's move on to non-healthcare costs. So I wanted to focus on 4 things. There's increased frailty, cognitive decline, loss of independence, and loss of work days and income by family members. Increased frailty is both a phenotype and a deficit accumulation. So phenotype is what the patient looks like. So they may have unintentional weight loss, weak grip, exhaustion, slow walking speed, and low physical activity. Oftentimes these are exacerbated by time in the hospital, time away from their usual routine, and then loss of muscle strength because of injuries. Deficit accumulation include nutrition, cognition, depression, functional decline, increased number and complexity of medical conditions, and social vulnerability. Again, when somebody is in pain, when somebody's on mind-altering medications like narcotics to control that pain, when they're outside of their normal routine, it can be a big setup for cognitive decline and other risk factors for frailty. Within the hospital, we take extreme precautions to prevent delirium, but we're still not very good at it. It increases healthcare costs, both at the index hospitalization, increased costs because they're discharged to a facility at higher rates, and then increased rates of dementia by approximately 10% of dementia is thought to be initially caused by delirium, which then increases, that doubles healthcare costs down the line. And delirium and dementia also increase social costs by causing isolation of the patient, but also isolation of the family member, and increasing the amount of unpaid work that family members and caregivers are having to provide for the patient. Some ways that I wanted to point out some ways that we try and prevent delirium to help reduce these costs in the hospital. Number 1 is keep them awake during the daytime so that they sleep well at night. Loss of a normal sleep-wake cycle is probably the number 1 risk factor. And it starts the moment they show up in the emergency department, which is almost always late, especially at University of Kentucky, where we have a very large transfer volume. So they start at a different hospital closer to their home, and then they are transferred to us several hours away usually. So they usually arrive either very late at night, very early in the morning, or sometimes in the afternoon, and they've been up all night. The emergency department rooms don't have any windows, so it's very hard to tell when it's day and night. We try and turn the lights on during the daytime, keep the windows open if you're in a regular room, have glasses, hearing aids, any other assistive devices. Having a family member is very, very helpful to help reorient the patient. But again, this is unpaid work. people are losing days of work and income that's related to that. So that can be very challenging. And then family members who are living far away also have to find a place to stay if they don't want to stay in the hospital with us the whole time. And it can be quite expensive for them. We also sometimes give medications to help sleep, like melatonin or trazodone. Keeping them busy. Again, we have fidget vests. The nurses will give them chores to do sometimes, like folding towels or sheets, just to keep their hands busy. But bringing patients activities to do during the daytime is also helpful. And then again, loss of independence. I always heard that sort of for an older adult, a day in bed is really worth a week out in the real world. So in the hospital, people lose their ability to maintain their activities of daily living very, very, very quickly. They eat poorly because they're in pain, because they're nauseous because of pain medicine, or the anesthesia. It's a very normal response to trauma to have a poor appetite at first, sometimes for several days, and elderly people tend to not regain that very quickly. Sometimes weeks or months later, their appetite will still be altered. There's sort of a level of non-compliance with medications that occurs when you enter the hospital, and it's usually intentional. We usually figure out what your medications are within 24 hours of you arriving. We have very good pharmacists at the University of Kentucky, but sometimes you're just not appropriate for restarting certain medications because you have a head injury, so it's difficult for us to justify restarting certain anti-dementia medications or psychotropic medications, or your blood pressure is low, so we don't restart those things, which then can throw you into new onset or uncontrolled atrial fibrillation, which then adds to the medications that we have to start that are new. So there's a lot of medication Jenga, basically, where we're trying to figure out exactly what's going to be required to keep the patient going and not let the stack fall over. Loss of social networks, both in the hospital, out of the hospital, in rehab, whether or not they are discharged home eventually or to a nursing facility, can really alter who they're in contact with. And then again, loss of hobbies. If you don't have anybody to bring you your knitting or to bring your cross stitch or to bring the crossword puzzle to you or a book, or you lost your glasses in a car wreck and you can't read or see the TV, it can be very challenging. And then caregiver costs. Caregivers are often family or friends. I'm an eldest daughter. We tend to take on a lot of the burden of caregiving for our older parents. You know, caregivers lose work days for appointments for hospitalizations just because the patient has to be with somebody 24/7. Sometimes they can't find anyone to stay with them even at home. So they have to take off work. Some people have to quit their jobs and become a full-time caregiver. This also socially isolates the caregiver because they're not able to sort of maintain their usual routines, can cause increased stress and anxiety, which reduces the caregiver's health as well. Questions? Sorry, I'm just checking the chat. Someone said that this is definitely a very overlooked cost of falls, caregiver support, and work. Yeah, most definitely. I wanted to focus on 3 falls prevention or risk prevention programs and their costs as well. Exercise, which includes lower limb strengthening, balance, cardio, stretching. Usually, at least in the studies that I've read, was about 60 minutes for 2 or more times a week. This can be done individually or in a group. Environmental modification, evaluation by an OT, removal of hazards in the home, which I think some people have spoken on. And then osteoporosis screening and treatment, identifying via a DEXA scan and treating older adults with osteoporosis. So the first intervention was exercise. Sorry. Implementation costs range from very, very cheap at $64 to over $500 per participant. And overall, the cost per fall prevented was about $840. The willingness to pay threshold is at what dollar amount are people willing to pay for a quality adjusted life year? And it's actually pretty low compared to other interventions. So people value exercise at $18,600 for quality adjusted life year. And then there are some studies that said resistance training may be more cost effective than balance training. Though most programs include both. And then environmental modification can show an absolute risk reduction in falls of 38%. In one study, they had 1.5 falls per year for environmental modification versus 2.3 falls per year, which was just an educational pamphlet, basically. Quality of life and daily activity were unaffected. So modifying somebody's environment doesn't necessarily change the way they move about their day. It just makes it safer. So that's good. The implementation costs are about $765 per participant, but there was 111% return on investment. So this is a pretty easy sell. There's just got to be people to do the environmental modification and to go to people's homes to do it. And then people have to know about the program. And then osteoporosis screening and treatment. This doesn't necessarily reduce fall rates, but can reduce injury rates if somebody does fall. It's a little bit more expensive. The incremental cost effectiveness ratio was $33,000 per quality adjusted life year. And the willingness to pay threshold was higher at $100,000. And then during my reading, I saw some interesting things that might be up and coming with AI-based falls prediction systems and VR training programs. Obviously, the older adult generation we have right now is not as into technology and VR training, but as my generation gets older, that's certainly going to be something that will be, I think, interesting for us. And here are my sources. Let me stop sharing. Okay, sorry. Someone, Caroline asked, isn't there a waiver where family takes full-time care of their elder members, they can be compensated? Yes, I believe there is. If the person is, the older adult is living in that person's home rather than a care facility, there is a waiver, but from my understanding, it doesn't necessarily cover what a full-time job might cover. And then you also have sort of loss of benefits for that person. So retirement benefits, healthcare benefits, things like that. Brian said, out of curiosity, are you and the ortho trauma team working closely with Dr. Rao and her osteoporosis bone health clinic team to identify and refer patients to them to ensure patients get appropriate long-term treatment and management of their underlying osteoporosis? I have heard of Dr. Rao's program. She's got some NIH funding for it. And we are working on developing a referral system as part of our like automatic order set for falls. I know that Dr. Mogadamian and Dr. Wright with the ortho trauma team are much more plugged in with her than we are currently, but it's something that is on our radar and that we're working on. She's doing really great work. And then
Alexis, I don't know if you wanted me to chime in.
Oh yeah. Hey, Shannon.
Hey, hi. Um, so we do have actually for our fragility fractures, and it's kind of limited just to our hip fractures as far as automatic, but like Alexis says, we're working to kind of roll it out to all of our fragility fractures. But our hip fractures all go to their first orthopedic follow-up on the same clinic day. So it's like every other Friday, we have a fragility fracture clinic where Dr. Rao's team's actually partnered with our orthopedic team, and they have a dual follow-up where they get their bone health and their first post-op appointment. So that's where we've started. And like Dr. Nichols said, we're trying to do that for all of them, but she's got to have a little more bandwidth to her team too. But it's some good stuff for sure.
Yeah, that's awesome. Bryce said that for approved disabled veterans, there's a program that can pay for aid and attendance or housebound benefits. So that's good to know. And Ashley asked, do you have an estimate of how many of your patients are repeat patients? Once a fall occurs, the secondary fall risk increases substantially. Yeah, it is. I don't think I could give you a number right now. I could probably tell you the number of repeat gunshot wounds we get, but for as far as falls, I know that we all see the same names pop up over and over again on occasion. But I don't have a number for you. I apologize.
Very good. I do have one side comment about the caregivers. I understand from personal experience in the last year or two what it's like to slowly move into being a caregiver. By this, I mean my 89-year-old mother is in Moorhead. I'm in Winchester. There's no other family members within 4 or 5 hours. And mom refuses to sell the house, to move, because her church is there, her friends are there, her physician is there. So when it comes to caregiving, I guess what I'm trying to say, it's not always so easy to get the message across. You're at this stage of life. These are the issues you have. Stop being hard-headed, so to speak, if you know what I'm trying to say. And,
Yeah.
it's just moving into the role as a caregiver can be very stressful in so many ways.
My mom and her brother, my uncle, are going through the exact same thing with my grandmother right now. So she had a fall. She thankfully was not injured, but she's moving into an assisted care facility this weekend.
My mother has talked about it for the last 5, 6 years, but will not make the jump, will not make the move.
Yeah.
And I'm thinking, okay, if she lives another 5, 6, 10 years, because she's already got a wheelchair there, bunch of walkers, canes. She has fallen, wound up in the emergency room at least 3 times this year. You see what I'm trying to say?
Yeah.
And the
Sure.
toll, just not on the older individual, but also on the caregivers who are usually family members, from what I've seen, can be, as you mentioned, very costly in so many ways.
I think one thing that I try and impress upon our residents and our nurse practitioners and PAs and my partners even is that understanding a patient's goals for life before we embark on any sort of treatment plan is incredibly important with any patient, but with our older adult patients in particular, I think, because they may only have the ability to do certain things that bring them joy, right? Like gardening or, like they live for spring so they can get out and plant their flowers, or they really enjoy taking their dog for a walk or whatever. And if they can't do those things in the end, they're just gonna spiral, right? The cognitive decline is going to happen, the depression is going to happen. And for them, life might not be worth living. So that can completely change your treatment plan and the treatment focus. So I like to get to know my patients' goals a little bit more before we embark on any sort of treatment plan. And I start in the emergency department and just get to know them and what they like to do. Because that can really affect the quality of somebody's life after a fall, I think, and at the end of their life. So
Yes. I agree. Very much appreciate the information, like all the other presentations, very relevant to each of us and our loved ones. Uh, a lot of the information within your slides and thoughts, ma'am, about what not only we're facing now, but the future as well.
Yeah. Thank you. I appreciate the opportunity to come talk.